Hello everyone, welcome back to Cancers 101. I'm your host Rittika and today we are tackling a topic that lives right at the crossroad of hope and risk. Tissue transplants and their link to infections and cancer. Organ and stem cell transplants are life-saving, but like opening a heavy guarded gate, they often require immunosuppressive drugs to keep the body from rejecting the transplant. The flip side, you may ask? The open gate may also invite opportunistic infections and even certain cancers. As always, I'm joined by Aditi. Aditi, tissue transplants truly are a double edged sword, aren't they?
Absolutely. Immunosuppressants like tacrolimus, cyclosporine, or steroids are critical for preventing graft rejection in organ and bone marrow transplants. But long-term suppression of the immune system weakens the body's ability to detect and destroy abnormal cells, leading to post-transplant lymphoproliferative disorders or PTLD, a form of lymphoma triggered by unchecked Epstein-Barr virus replication.
So it's like turning off your home security system to let a friend in and then only realizing that there was a thief snuck in behind them. So the very drugs that protect the transplant can also set a stage for virus driven cancers. And infection, oh boy, are relentless in this context. Think of transplant patients as walking a tightrope between immune protection and immune suppression.
Right. After stem cell transplants, especially allogenic ones, patients are highly susceptible to infections like cytomegalovirus (CMV), which can cause pneumonia, colitis, or retinitis. BK virus, often leading to hemorrhagic cystis in bone marrow transplant recipients. Fungal pathogens like Aspergillus or Candida, which can spread systematically and be fatal.
And these aren't just annoying bugs. In the context of cancer, these are life threatening complications that can derail the entire post transplant recovery process. Let me take you through the sobering case. So, a 17-year-old girl with acute myeloid leukemia underwent a matched unrelated donor stem cell transplant. Everything went well initially, but 3 weeks in, she developed a high fever and breathing difficulty. CT scan showed diffuse infiltrates in her lungs.
Turned out to be invasive pulmonary aspergillosis, a fungal infection. Despite antifungal therapy, her condition worsened. Immunosuppressions had to be reduced, which increased her risk of graft versus host disease. It was a delicate balancing act, and sadly, she passed away within 2 months.
This case underscores how even a well executed transplant can be overshadowed by opportunistic infections, especially when the immune system is both an ally and an enemy. So, how do clinicians walk this tightrope, Aditi?
It's all about monitoring, timing, and tailoring. Key strategies include regular viral load monitoring, especially for CMV and EBV, preemptive therapy, treating viruses before symptoms arise, tailored immunosuppression, adjusting drugs based on infection or relapse risk. Last but not the least, prophylactic antifungals like posaconazole in high-risk patients.
It's like managing a thermostat too hot and the immune system attacks the graft, too cold and the infection or cancer can creep in. This sweet spot requires constant calibration. Let's bring it all together. Tissue transplants offer a second chance at life, but they come with a burden of immunosuppression, which can open the door to both aggressive infection and virus related cancer.
We have come a long way with diagnostics, antivirals, antifungals, and immune monitoring, but the balance remains fragile. It takes a multidisciplinary effort, oncologists, infectious disease specialists, transplant physicians, to make sure patients don't just survive the transplant but thrive beyond it.
Transplant may be the miracle, but it's the daily vigilance that makes them work. Thanks for joining us today on Cancers 101. If you found this episode helpful, share it with a fellow researcher, clinician, or a student.
And don't forget to subscribe. We have got more deep dives coming your way.